he has also introduced microscope to the field, which was truly a major breakthrough in dentistry. And I'm so grateful that he accepted my invitation to be here, and I'm sure you are going to enjoy his presentation. Thank you so much, Dr. Carr.
Thank you, Hasim. Thank you. Can you hear me okay? Well, it's a pleasure to be here. I've spent most of my professional career lecturing exclusively to endodontists and talking about things that either I have developed myself or my own cases. So there's always been kind of a certain level of comfort in speaking to my peers. And today, of course, that level of comfort is gone. I'm not speaking just to endodontists, and I'm speaking about things where I had no part in the development of this material. None of this material is mine. As Steve mentioned, some of this material is hundreds of years old. And so it's kind of scary being up here talking about something that I'm not really an expert at. And actually, that's why I accepted this assignment. Being scared is good, at least from my perspective. So this slide kind of epitomizes an idea that I hope to get across today. The whole problem with the world is that fools and fanatics are always so certain of themselves, and wiser people are so full of doubts. The topic is evaluation of diagnostic performance in cone beam imaging. And my disclosure is I own and develop an endodontic software program called TDO. I have an instrument company that manufactures and sells instruments of my own design. And I have a nonprofit research foundation dedicated to mostly biofilm research, but some cone beam research. And I'm not going to talk about any of these things today, so there shouldn't be any conflicts. I always like to start by acknowledging certain people. First and foremost, John Cotomy, who had the courage to come up to me when I was first trying to do some serious work in cone beam imaging and say, hey, Bed, you better do some reading here before you make a fool out of yourself. And I'll be eternally grateful to John for leading me in the right path and for really being one of my mentors. More about John later. Kevin Birbaum, who is one of the world's foremost experts on ROC analysis, and came out and spoke to us at TDO several years ago, and has probably done more in this field to understand how to evaluate the diagnostic ability of different medical imaging tools. And I certainly wouldn't be have anywhere near of an understanding if it wasn't for Dr. Birbaum. And by some strange coincidence, he was also John's advisor on his master's thesis. Strange how these things happen. And of course, my good friend Peter Endo and Carlos Murgel, who have been so generous with their time doing the cone beam cadaver studies, and those studies could not have been done without their contribution. Because part of this lecture is designed to maybe stimulate you to do some reading and get interested in this, I'd like to kind of just briefly review the sources that have influenced me. First and foremost is Kahneman's Thinking Fast and Slow. He's the only psychologist who's actually won a Nobel Prize in a different field, economics. And this book can really help you get your mind around kind of where the sources of your biases are and what the problem is in understanding base rates And this book can really help you if you have interest in this field. I would recommend reading this first. And then The Black Swan by Taleb is another book that can really have you understand uncertainty a little better. And he talks about this characteristic called epistemic arrogance. And for some reason, physicians and dentists are really susceptible to this kind of arrogance. And he can really help you maybe make a breakthrough on maybe not being so afraid of your uncertainty and actually knowing when you know something and when you don't. This is a book, one of the books that John gave me, that really goes over the perceptual and cognitive areas in cone beam imaging. That the background material in this book is absolutely crucial to developing any kind of sophisticated understanding of what's happening in cone beams. And this book can really help you understand how the image is actually created. And there is no sophisticated understanding or reading of cone beams without having a pretty good understanding of how that image is generated, how it's reconstructed, and how artifacts are produced and interpreted in cone beams. So this is a very helpful book as well. For those of you who are mathematically inclined, this is one of the giants, intellectual giants of the 20th century, I think. And if you have a mathematics background, this can really help you develop a very good sense of what Bayes' theorem really means. Two papers that are basically all you really need to read as far as what I'm going to talk about today, because my talk basically comes from these two papers. Paul Chang's paper on a radiologist survival guide, and John Cotomy's master's thesis really applies this to dentistry. Both of these papers really give a very good summary of the things that I'm going to be talking to you today. You can Google this, it's available. I'm sure if you email John, he'd be happy to send you a PDF of his master's. It's also another one of those really strange coincidences that Paul Chang was John Cotomy's advisor on his master's as well. And finally, our speaker this morning, Dr. Goodman, over a 20-year period, he's written these papers on kind of understanding how we evaluate the strength of our evidence. And most of these papers are available for download on the web, and they're really an inspirational source of understanding about how to really evaluate evidence and what a p-value is. And you saw that on display this morning. These are papers that at least I do, I have to read them over and over again to really get a sense for how to evaluate evidence. So those are my sources. I'd like to start out with just a story. So this is Cindy, and she came to me wanting to have a crown placed on that central incisor, and seemed like a relatively straightforward case. And she comes in with a radiograph, and the radiograph looks like this. This root canal had been done close to 20 years ago. Never any symptoms. No palpation, percussion sensitivity. The dentist just wanted to know whether we should redo this root canal before he started his prosthetic training. So she comes in, I look at it, I take my radiograph, and I go into my usual spiel. You know, Cindy, this is kind of a judgment call. These are the advantages of treating it. These are the disadvantages of treating it. It's really, if it depends on the question you're asking me. If you're saying, do I have to have this retreated? My answer is no. If you're asking me, should I have it retreated? My answer is, I'm not really sure. I don't know. So then she says, well, what about the cyst on the tooth? And she said that the prosthodontist said I had a cyst, and he said it showed up in the cone beam. I said, you have a cone beam with you? And then she brings out this piece of paper, evaluate cyst at the apex of number 9. See photos and Newtome scans. So she goes to her purse, she brings out this slip of paper that she didn't give me, and then she gives me the disc, we load the disc, and this is what I see. So, I don't know. This is the cyst, apparently. So, I'm just kind of looking at these, not really knowing what to say, and trying to plan how to look like not a complete fool. And so she says, so Dr. Carr, do you still think it's just a judgment call? Now, I don't know about you, but I don't like looking like a fool in front of my patients. So these are just part of the Newtome scan. You can see the amount of bone loss. So of course, we retreated the tooth. I have a lab, so we looked at this very carefully. We did some live dead stains showing a lot of living and dead growing in a biofilm. This is what that cone looked like in one area with many different species of bacteria. This is a TEM we did showing the little dent and chips on it just filled with bacteria. And this is, when I took the cone out, this is the pus that came out. We looked at the pus. So if you've never seen pus, this is what pus looks like. And that's the final case. And that's it 5 years later. So the case had a happy ending, but about 3 days after that case, I went out and bought a cone beam and put it in my office. Thinking that I really needed to have a cone beam to really see this. So even though there was a happy ending here, there are some inferential errors that are made in my thinking process about why I should get a cone beam and scan my patients. So part of the point of this lecture today is maybe to outline some of those inferential errors that I made, some inferences that we drew from this one particular case. I don't regret my decision, but I do regret the reasoning I used to go out and get a cone beam for my office. Okay. So when John said, you better do some reading before you make a fool out of yourself, Carr, he gave me some books that actually, when I started to do the cone beam research in my foundation, I didn't actually read any prior research because at that time, no one had really done any endodontic research on cone beams, and there wasn't really much in the dental literature other than for implant placements and that sort of thing. There wasn't much from a diagnostic point of view. But in fact, so I didn't read any very much about what had been done, and of course that was a really big mistake. Because there's a tremendous amount of work that's been done over a 30-year period on diagnostic accuracy on these sophisticated medical tools. And had I read or been familiar with that literature, I wouldn't have wasted so much time in our lab doing work that really didn't have much meaning. So let's answer the question. How have skilled professionals studied this? What are the standards that people should use when they're evaluating any imaging tool in medicine or dentistry? And it turns out that Kevin Birbaum has contributed a lot of the really sophisticated research on how diagnostic accuracy should be approached, how it's measured, and it's some very careful work on how the diagnostic accuracy of these tools is actually measured. And a spin-off of the Cochrane collaboration is this STARD statement for the reporting of studies on diagnostic accuracy in imaging tools. And so this statement is, like the Cochrane collaboration, lists 25 items that should be listed in every imaging study that's done. And we obviously don't have time to go through all of these, but every single one of these are important. And I'm not familiar with all of the cone beam literature in dentistry. I'm familiar with most of it in endodontics. And there isn't a single study in endodontics that has even 5 of these included, and all 25 are required as kind of a standard. So our standards on determining diagnostic accuracy with this imaging tool really is kind of almost a third world kind of standard, and that's being insulting to the third world. So most of these items have to do with sensitivity and specificity, how patients are recruited, how the sampling is done, how you evaluate who is reading the radiograph, issues with prevalence in the sample population. For example, tests may perform differently in a primary care setting than in a secondary or tertiary care setting. Our literature is rife with these kind of errors that are made just simply in our sampling that really skew the results of determining, or the conclusions made in how accurate these devices really are. And then it ends with kind of a consort statement where every imaging research project actually has to have a flow chart that accounts for every single patient and every single test result in that experiment, so that you can eliminate really any kind of hidden source of bias. So I don't know if there's any journal editors here, but I think, as Steve said, our peer review process in dentistry is really broken. And so if you're on a peer review panel and you're evaluating a paper on any of these imaging tools, take a very good look at this STARD statement. This is the website, stardstatement.org. And no paper really should be published, if you want to have a high standard, without conforming to all 25 of those items. So the first thing when you start reading literature on how real professionals look at this is they have their own language that they use. It's a very specific language. And we're going to talk about most of these items today and just have kind of a definition of what it is we're talking about, so there's some clarity really when people talk to each other. So the typical definition of diagnostic accuracy is that it relates of an ability to an imaging test to discriminate between health and disease. That's what any kind of a test is designed to do. If you're doing a test on periodontal disease, you need to distinguish between people with periodontal disease and people without it. But when it comes to imaging, there's a problem with this definition. When you go to your van that comes around your area and you have your full body scan, does that scan actually see health? Is that what it sees? Does it see disease? And maybe the general public thinks that the machine is detecting disease. But it really doesn't see disease, does it? When you look at this, how are those x-rays look? Do they look okay? Yeah, okay. Can you tell me, does the x-ray tell you whether this pulp is healthy? You're looking at the ligament space. Could you tell me that there's disease here Does it see disease? So it's a very inaccurate way. What you're really saying is, what I see is a normal radiograph, therefore I infer that there is no disease. So there's an intervening inference that may be true, it may not be true. But for certain, the imaging test itself does not see health or disease. It just sees a picture. And you need to make an inference from that picture of whether a patient has. This may seem like a pretty picky thing to you, but it isn't, because there's occult inferences being made all the time. Our literature is rife with these occult inferences that many of them are incorrect, and therefore we're reaching the wrong conclusions. So let's change the diagnosis and say, or the definition, and say diagnostic accuracy relates to the ability of a test to discriminate between a target condition and health. Okay, we're getting warmer. A target condition may not be disease, right? It's just a target condition, whatever that is. A thickened periodontal ligament, a shadow on a radiograph. That's the target. The lack of a canal seen in a radiograph. The target condition is just simply a finding that you describe on a radiograph. But the other part of the definition, I still have a problem with this. Because it's not distinguishing between a target condition and health, because you can't see health. You have to infer health, right? You have to infer health. Now, your inference may be right, but it may be wrong too, as we'll see. For example, this was a referral from mine, I think about 10 years ago. Patient had a ski accident. The number 9 is discolored. I take a picture, I see a target condition there. I want to be certain, and I'm saying, this is not healthy. But actually it is healthy, because if you take an occlusal, you see that. Okay? So when we go back to our definition, we don't even want to have health in there, because an imaging test cannot tell you whether you're healthy. It can't tell you whether you're diseased. It requires the intervening inference to make that case. So let's refine our definition a little differently. Diagnostic accuracy relates to the ability of an imaging test to discriminate between a target condition and a normal image. Now we're getting somewhere. I can buy into that definition, because that's all you're really doing. This image is normal, this image isn't normal. I can then think about, well, because it's abnormal, I can infer whether there's disease, or I may infer that there isn't disease. This is a perfect example. This is a case Jeff Pafford sent us in our chat room in TDO. What do you see there? Do you see health or disease? No, you see something that isn't normal. That's all you see. Don't infer that that is disease, because if you do, and this is happening all throughout our specialty, you're going to make a lot of mistakes, a lot of errors, because 4 weeks later, he took another radiograph, he didn't do anything, and that's what he sees. And all that happened here is that this little spicule of bone, when the radiograph was put in the mouth, this was traumatized. And that lingual plate of bone got a little ischemic necrosis, and that's what resulted from it. As soon as this bone healed, that tooth went back to normal. That's not what I call disease. That's just a normal physiologic remodeling process. So when we see an abnormality, we don't say, well, you've got a lesion there. You don't know if it's a lesion. Maybe it's a lesion, maybe it isn't. So to speak correctly and clearly, we say the image is perturbed. Okay? To say it's a lesion would require a gold standard, which we don't do on our patients. A patient doesn't come in to me with an abnormality in the apex of their molar and I don't take a biopsy, a needle biopsy, to detect whether there's actually disease there. I infer that there's disease, but when I talk about that, I just say that the image is perturbed. And I think even in speaking to each other as peers, or even in speaking to our patients, this kind of accuracy is important, because decision-making is going to occur from these words that we use. I love this case that came out of Dr. Birbaum's lecture. The validity of a diagnostic test cannot be established by the use of the diagnostic test alone. It must depend on additional examinations, tests, observations, and data provided by sources other than the specific diagnostic test under study. What is he saying there? He's saying that it can't tell you whether you're healthy or diseased. That information has to come from somewhere outside of the test, from other tests, from prior information, but it can't come from the test itself. And many endodontists, I don't know about in other areas, I'm very familiar with the endodontic, many endodontists make this mistake, that they think they can see disease by looking at their cone beams. And this is another problem. Knowing if an image is perturbed, doesn't that require that you know what normal looks like? If you're going to say this is abnormal, you have to have some range where you know what normal like. And this is our problem in endodontics, in regard to cone beam imaging, is that none of us actually know what normal looks like. And the reason we don't know is we haven't looked at enough of these. We don't have the domain expertise to know what is the range of normal, what is the distributions of finding in normal. We think, because we know what normal looks like on a periapical, that therefore we know what normal looks like on a cone beam. But in fact, that is not true. And we're going to cover this later in the perception and cognition part. But we have actually no domain experience in reading cone beams, and it's going to probably be about 10 years, maybe even longer, before we actually know what normal looks like. So already you can see we have a problem. Now, when you look at this, what can you tell me about that? Is this disease? We don't know. All we can say is that the image is perturbed, right? It's not normal. Because remember, the test itself cannot tell you this. What do you want to know? You want to know all about this case. When was this root canal done? What did the shadow look like 10 years ago when this root canal was done? This could be a scar. It could be just physiologic resorption. It could be all kinds of things. You just don't want to jump to the conclusion, this is an abscess. And that's what we tell our patients, you have an abscess. And this really makes the conversation with the patient much more difficult and much more dishonest. It's a dishonest conversation. It's not an ethical conversation, simply forced by the words that we use. And in fact, this is not diseased. What about this? Can you say this pulp is healthy because you don't see anything here? No, you can just say, you know, this image doesn't appear to be perturbed. That's all you really can say. So we don't say, I see a lesion there. We say that there is a finding, a target condition. There is a finding that is abnormal, or the image is perturbed. That is speaking accurately. What about this case? Let me go back. What do you think? I'm pretty comfortable saying that that image is perturbed, that it's abnormal. I'm not comfortable saying that there's an abscess there, though. And that affects my willingness to treat this. And I don't really know about this unless I know what the pretest probability is. That's why Bayes is so important. You can't do this kind of clinical diagnostic at a high level without knowing, by just looking at the imaging test. You have to have some prior information about the case.